get a ladder?
All right, everyone, let's go ahead and get the round started. Dr. Sharma has picked an interesting topic. Let's talk about PANDAS. And as you see from the slides, it may not be the PANDAS that you're familiar with, but it's a really interesting topic, an important one for anybody who takes care of children. So, Sonia?
Thank you. Good morning, everyone. Can you hear me okay? All right. So I picked this topic. I'm going into diabetes. This is not diabetes. I picked this topic mostly because I felt like it was something that I had heard about in medical school, maybe once or twice, but we never really discussed it. Didn't really know, just knew that strep infection and OCD was a thing. So I thought this would be something that would be nice to discuss and kind of look at some of the studies, and there's a little bit of controversy around this topic as well. So without further ado, I have nothing to disclose. My objectives are, I would like to define criteria for what PANDAS actually is, what it stands for you. We want to discuss the history and some of the controversy that surrounds this syndrome, and identify some of the possible treatments and really talk about the updated treatment guidelines that they just released last year. So what is this? What does it stand for? So it stands for Pediatric Autoimmune Neuropsychiatric Disorders, and these are associated with strep infections. So the research really began in the 1980s. The National Institutes of Health and the National Institutes of Mental Health were doing some research around Sydenham's chorea. And as many of you should know that Sydenham's chorea is a manifestation of acute rheumatic fever. And so they found that there was some basal ganglia involvement of Sydenham's chorea, and there were some neuropsych and neuroimaging and some antineuronal antibodies that they saw both in Sydenham's chorea and OCD. So back in 1998, Dr. Susan Sweeto, through the NIH, thought that there may be some relationship with group A beta hemolytic strep infection and OCD. So she sort of was the pioneer behind this term for this PANDAS syndrome. So I'm just going to talk a little bit about the diagnostic criteria for PANDAS. There are 5 criteria that the patient has to meet. Number 1, they have to have a presence of OCD and or a tic disorder. They have to have an age range between 3 years and puberty. The episodic course, it's mostly abrupt onset, so something like overnight onset of the symptoms. And the exacerbations really need to be associated temporally with group A beta hemolytic strep infections. So ideally, the infection is prior to the symptom onset or symptom exacerbations. And then finally, there has to be some kind of neurologic abnormalities, such as motor hyperactivity or some kind of adventitious movements, like choreiform movements or tics. So this first study that I'm going to talk about is Dr. Susan Sweeto's study back in 1998. You can see it's just a clinical description of the first 50 cases. The inclusion criteria here is pretty obvious. They have to meet all 5 diagnostic criteria for PANDAS syndrome. The exclusion criteria really involves the following. So if they had a history of Sydenham's chorea, any rheumatic fever, any other autoimmune disorder, or if they had any kind of cardiac abnormalities consistent with prior rheumatic carditis. So some of the assessments that they use, for most of these studies, they're 2-prong assessments. So they do a neuropsych or a clinical assessment, and then they do the lab assessment. So in this particular study, they used multiple different scales to look at OCD. They looked at tic severity ratings. They looked at and the NIH ratings for OCD, for more global assessment scale, as well as depression and anxiety. And so the lab tests, as you probably would expect, would be some pretty basic things like CBC, CMP. They looked at osmolality. They looked at thyroid studies. They looked at inflammatory markers like ESR. And then they looked at your basic stuff like your throat cultures and your antibodies. So when I'm talking about antibodies, I'm talking about anti-streptolysin O titers and the anti-streptococcal DNase B titers. So the results of this really show that there was an association with strep infections. In about 42% of the clinical cases, there are only 50 cases. So it really isn't only about 21 children that they saw this. A couple of the limitations that are really important to sort of mention is that, of course, this was a retrospective study. And also, most of the patients were pulled from the local Tourette's syndrome association. So that could have caused sort of this overrepresentation of Tourette's or tic disorder rather than OCD. You know, they're trying to say that both of these disorders is associated with PANDAS syndrome. So I want to take a moment just to talk about some of the diagnostic criteria for both tic disorder and OCD. Just as a refresher, I know all of you know this. So in tic disorders, this is just a rapid, recurrent, non-rhythmic, and stereotyped movements or vocalizations. They can be simple, they can be complex, and they're usually suggestible. This occurs in about 11 to 20% of school-aged children, and there is a male predominance, so it's about 2 to 3 to 1 in females. The onset for this is usually about 2 to 7 years old, and then it peaks a little bit later, around 9 years old. I do want to mention that there is a scale out there. I kind of talked about it with the last slide. It's called the Yale Global Tic Severity Scale, or the YGTSS. And this scale is between 0 and 50. So 0, of course, is no impairment, and 50 is considered severe impairment. I only mention this mostly because in some of the prospective studies that I'm going to be talking about a little later, they use this scale and a scale for OCD as well. And then there are 3 types of tic disorders. It goes from really minor to more major in severity. And so the first type is the transient or provisional tic disorder. Usually these are motor or phonic tics that last for at least 4 weeks, but not longer than a year. The second type is a persistent. These are motor or phonic tics that last for more than 1 year, but there are tic-free periods less than 6 months. And then, of course, you have Tourette's disorder, which I think is the most known one, and that's usually motor or phonic tics that last more than 1 year and also can cause distress in multiple social arenas for the patient as well. And then OCD, as you all probably know, it's obsessive compulsive disorder. Usually it's a presence of an obsession, so that can be recurrent or persistent thoughts, urges, or images that can be intrusive or unwanted, and or compulsions. And so these can be repetitive behaviors or mental acts that an individual needs to perform, mostly in response to the obsession, or if they have very rigid rules that they have to follow in order to relieve the anxiety that they experience. And so the prevalence of this is mostly, in the general population, is 1 to 3%. I really couldn't actually find a very clear-cut data on what it is in children, but there is a bimodal age of onset. So the earlier onset is usually between 8 to 12 years, mostly seen in the males, and they usually have a poorer prognosis. And then in the later onset would be after puberty, seen in predominantly females and have a slightly better prognosis. And the scale here that I talk about, the CY box scale, which is the Children's Yale Brown Obsessive Compulsive Scale. That is also a scale between 0 and 40. So 0 would be subclinical symptoms, and then 40 would be the more extreme symptoms. So the first case I'm going to talk about is a retrospective case control study. It was by Mel et al. This study included about 144 patients, and these were HMO patients. They were all out of Washington State and King County. The inclusion criteria for this study was that the patient had to be in an age range between 4 and 13, and they had to have a first diagnosis of OCD or chronic tic disorder or Tourette's syndrome. The exclusion criteria for this study is that if the child had ADHD, they were excluded from the study. And this study basically spanned a time period of 2 years. That was considered sort of the observation period. And the method that they used for this study really was to look at lab databases and see if they had a prior streptococcal infection before they had onset of symptoms. And so the results of this study, here you can see the first 2 lines I've highlighted for you. This first one shows that strep within 3 months of onset of all the cases has an odds ratio of about 2 with the statistically significant 95% confidence interval from 1 to 4.6. And then this other line that I've highlighted is the strep within 1 year of onset of all the cases that they looked at also had a statistically significant confidence interval of 1.2 to 3. What does that mean? I never know what these statistics mean. So really the breakdown is that the control cases were twice as likely, the PANDAS cases were twice as likely as the controls to have had at least 1 strep infection within 3 months or within 1 year. And so the next slide just shows the group A beta hemolytic strep infections. And again, the cases were twice as likely to show that they had the infection prior to the symptom onset. And so here you can see the confidence interval is significant. And so some of the strengths of this study that I was able to find was that they studied patients from an HMO. So the population was a little bit better in the sense that the patients weren't coming from a specialty clinic. They weren't being referred from a research group, so that they could at least do a little bit more generalization to the population. And then the second strength that they had for this particular study was that they were able to match the cases to the controls within the same primary care practice. So the same physician was seeing both patients. On the same side, there were some limitations because they were in the same primary care practice. The physician or the pediatrician was actually diagnosing the patient with tic disorder, OCD, or Tourette's syndrome. And so they weren't using a third party like neurologists, pediatric neurologists, or anything like that to sort of have an unbiased opinion. And then on the other kind of limitation to this study was that there was, around the time that they published the study, they had a lot of presence in the media. And so a lot of these physicians were actively looking for this association. So say the patient came in with symptoms of OCD that the parents said it was overnight onset, they would immediately check them for a strep infection. So they would do a throat culture or the blood tests. So that made a little bit of a bias for this study as well. The next study I'm going to talk about is a little different. So this is another retrospective study. This was in 742 cases, so a little bit larger than the last one from Mel et al. And they had over 3,000 controls for this study. And this study was done in privately insured children compared to the HMO group that we saw last time. So the objective here, of course, most of the objectives for all of these studies that I'm going to present are to assess whether an antecedent strep infection increases the risk. They looked at OCD, they looked at Tourette's, tic disorders. They also actually looked at ADHD and major depressive disorder in this one as well. And the data just wasn't there. I might as well just tell you that right now. So here are the results. I apologize, it is a little hard to see. But here you can see, or not see, I guess, that the confidence interval for strep within 1 year of onset of all the cases is 1.2 to 2. The strep within 1 year onset of OCD is 1 to about 2.8. And then the strep within 1 year of onset of a tic disorder is about 1.2 to 2.3. So I just kind of pointed out the clinically significant study. So the conclusion really was that the putative PANDAS cases were being diagnosed 3 times more frequently with strep throat, sore throat than the remainder of the cases. A couple of the weaknesses of this study is that because they were using such a large group of patients, they really didn't match it per provider. So unlike the last study where they had one pediatrician or one primary care provider doing both sides, both arms of the study, for this one, it was, they weren't looking at one provider, they were looking at multiple providers. And then the other aspect was that they were just looking at the data itself. They weren't looking to see if the strep infection was prior to or causing the symptom onset or exacerbations. And then what does this mean? I mean, I'm just telling you that, there's this theory that PANDAS is a thing that exists, but there was, of course, controversy surrounding this, this topic. And so the controversy was really brought about by another group of clinical investigators who said that they felt that the studies that I just presented to you had some weaknesses. And so they addressed each weakness here that I've listed for you. And we're just kind of briefly go through that. And then the studies I'm going to present for the next half is going to really talk about each point that they brought up. So the first thing that, and you may have already kind of read through these, but it's that there really hasn't been any standardization or validation for these studies for PANDAS diagnostic criteria. And then the second point that they brought up was that the ages seemed sort of arbitrary. So the ages that they picked, the 3 years to puberty, is just the age range that they found in the first 50 cases that Dr. Sweeto had published. So there really wasn't any kind of rhyme or reason to it. And then, of course, they really weren't able to quantitate the symptom severity of the tic disorder or OCD because they didn't use the scales or any kind of rating that I had kind of mentioned earlier on. And then finally, of course, they were all retrospective. And so there really weren't any prospective studies showing that there's an actual temporal relationship between the strep infection and the onset of symptoms. So the next few slides, I'm going to sort of talk a little bit about some of the studies that these investigators felt like, that they had published. They felt that the previous ones were weak in these points and tried to address some of these points that they were talking about. So the first one is from Curlin et al. It was also based out of the Tourette syndrome study group. So here we see already we're starting off good. It's blind, it's prospective, it's a case control study. The inclusion criteria for the PANDAS subjects or the PANDAS arm of the study, basically there had to be a temporal relationship for infection, and they had to have at least 2 clinical events. The 2 clinical events can be at least 1 symptom onset and 1 exacerbation or 2 exacerbations. And then they had to have lab evidence that there was actually an infection as well. So that could be a throat culture that was positive. It could have been the ASO or the DNase-B titers as well. And it had to be present for at least one of those events. And so then the control subjects here, basically their inclusion criteria was that they had to have at least the presence of OCD or chronic tic disorder per the DSM-IV criteria. And they also had to have a clinical course that was not related to the infection. And so they use, like I had mentioned before, the CY box. That's for the OCD, and the YGTSS, and that's for the tic syndrome, to sort of base their studies on. And they also looked at throat cultures as well as blood samples, like I had mentioned before. The throat cultures were done every 4 weeks, and the blood samples were done every 12 weeks. And this occurred over a time period of 2 years. One point that I thought was kind of interesting was that they had a separate clinical expert investigator really there to determine whether the patient had an actual symptom exacerbation. So it wasn't the primary care provider, it wasn't the authors, they had a separate person sort of determining that. And they had to have at least symptoms for a minimum of 5 days. The other thing that I thought was kind of interesting was that the subjects were being treated for these symptoms with mostly from either therapy or any kind of psychiatric medications, and so they were allowed to continue to take their medications during the study, and that clinical site investigator, who is the one who was determining whether they were having an exacerbation or not, was able to decide whether the patient needed to titrate the medications or, you know, either up or down. So they had that ability as well. And so what were some of the results of this study? So not that surprising, the large majority of clinical exacerbations could not be linked to antecedent bona fide group A beta hemolytic strep infections. And so some of the limitations or the weaknesses of this study that I found were that the study really did not address the association between the infection and the actual onset of symptoms. If you recall in all of my blabbering that I'm doing to you this morning, that it's either one onset and one exacerbation or 2 exacerbations. So I really feel like the data shows that they already had the diagnosis of OCD and tics, and they just were looking at exacerbations. And then the other limitation, which this will start to be a common theme here, is that the study was underpowered. The cases just weren't there. The numbers just weren't there for this study. The next one I'm going to talk about is another, prospective longitudinal study. It was from Luo et al. The objective here was to examine the temporal relationship between new infections and acute exacerbations. And so the inclusion criteria here was that the patient had to have an IQ of at least 75. I'm not sure how they did that in small children, but I'm sure there's a way. They had to be free of any kind of serious medical illness, any major handicap like blindness or deafness, if they had any major neurologic disease such as a seizure disorder, if they had any previous head trauma with associated loss of consciousness, and then if they had any current or previous psych disorder that prevented them from participating within the study. So that was more like the exclusion criteria, so they didn't include any of those patients. They did the clinical assessment in 2 stages. The first stage that they used was they had the patient, if they were old enough, and the family member do actually an inventory. So they filled out a questionnaire, and they also did the scales, the CY box scale and the YGTSS scale as well. Then the second stage of the clinical assessment part was that they actually had a site investigator go through the inventory with the patient as well as the scales to make sure that it was accurate and valid. So that was a clinical assessment that they did for this study. The lab assessment is really not surprising. I won't repeat all of it, but the two things that they did do that was a little different than your throat cultures and your blood tests, they looked at this peripheral blood B lymphocyte that was expressing the D817 surface antigen, which I had no idea what that was. But I believe it's a biomarker of cell-mediated immunity. And they also looked at another lab value, which was called neopterin, which was that is a pteridine that's produced by human monocytes via a Th1 immune response reaction, also another biomarker of cell-mediated immunity, as well as CRP. So the results are up here. You can see there really was no significant difference in patients with elevated ASO or anti-DNase B and the control subjects. Some of the limitations that they identified was that these patient population was mostly from a specialty clinic, so they really couldn't generalize this to the rest of the population. And then, again, low power of the study. So the study was underpowered. And then this is my next study. We're almost there, guys. Stay awake. Stay with me. So this was another prospective blind case control study. These patients were culled from multiple different clinics, whether they were psych clinics, neurology clinics, or primary care, or the primary care practice, from Yale, Cincinnati Children's, NYU, Hopkins, that's University of Alabama and University of Rochester. And so the inclusion criteria for these patients, if they were in the PANDAS arm, had to have, you guessed it, PANDAS. If they were in the non-PANDAS arm, they had to have presence of OCD or tic disorder. They had to not have any temporal relationship between the symptom onset and infection. And so the results you see here, there really was, the PANDAS and the non-PANDAS arm had pretty similar rates of exacerbations. And so the relative risk for PANDAS to non-PANDAS was about 1.2. And that means that it was a 95% confidence interval of 0.75 to about 2. So again, not really statistically significant here. A couple of the limitations I want to just briefly mention for you. They say it was a prospective blind study. It was mostly blind. They had one area that they had violated the blinding, and that was when the clinical investigators or evaluators did not know if the patient was positive or negative for strep. They did not know if the primary care physician was going to treat that infection either, but they knew that that patient was in the PANDAS arm. So I don't know if that really created any kind of bias or not. And then the primary care physician could treat the infection if they felt they had the ability to do that. They weren't limited by that. And if the primary care physician felt, or whoever, if it was the neurology clinic or the psych clinic, if they felt that the patient needed some kind of cognitive behavioral therapy to treat the symptoms, the authors, for some reason, didn't monitor that that patient had gone or not gone. And then the final limitation, which I'm sure you won't be surprised, is that there just was not enough cases in this study, and so the study was underpowered. You see a recurring theme here, I think. So what does this mean now? I've presented sort of the retrospective side of things, that, that there is an association. I've presented a couple of prospective studies for you that really don't show an very clear-cut association. So in 2013, Dr. Sweeto got together again with her colleagues and came up with a new criteria to really to push more research into really treating OCD and tic disorder. And so she termed this new criteria PAN syndrome. So PAN syndrome stands for Pediatric Acute Onset Neuropsychiatric Syndrome, mostly because there was such a difficulty establishing a tight link between strep infections and the disorder that they decided to broaden the criteria a little bit and try to be able to do more studies that would be, shall I say, legitimate. And so they would consider really PANDAS a subtype of PANS syndrome. And so just want to briefly mention the diagnostic criteria for PANS syndrome. There's 3 criteria that the patient has to meet, one of which is that there's an abrupt, dramatic onset of OCD or food restrictions, actually. So that was kind of odd. And then also they had to have symptoms that weren't explained by any kind of neurologic or medical disorder. And then finally, they had to have at least 2 additional neuropsych symptoms. And so those symptoms really, I'm just going to kind of list them for you. I didn't put them on the slide because that would have been horrible. Anxiety, depression, if they had irritability, or if they had any kind of oppositional behaviors, or developmental regression, if they were deteriorating in school performance, like one of the examples was their handwriting was getting worse, if they had any kind of sensory or motor abnormalities that follows along with that, or if the patient had any kind of somatic signs, so such as enuresis, urinary frequency, or any kind of sleep disturbance. So they had to have at least 2 of those symptoms that I sort of listed for you. So I want to just go a little bit back to some of the treatments that I found for PANDAS, not PAN syndrome, but actually for PANDAS, because that's my topic. And so some of the things that I found that I thought were kind of interesting were anywhere from prophylactic antibiotics, so penicillin and azithromycin. Of course, we use that in treatment. IVIG or plasma exchange, which I was sort of surprised about. Cognitive behavioral therapy, you expect that, and SSRIs, you also expect that as well. So, yes, you almost got free of no more studies, but there are 2 more to go, so just bear with me. So the first one is actually interesting. It's a pilot study of penicillin prophylaxis for these neuropsych exacerbations, so basically for PANDAS syndrome. And so the hypothesis here was that penicillin prophylaxis reduces neuropsych exacerbations. It was a placebo-controlled double-blind study. The patients were either randomized to receive PenVK twice daily for 4 months and then followed by placebo, or placebo followed by penicillin. And so the patients were monitored monthly, so they were monitored clinically as well as with lab studies done. So they used those scales that I talked about earlier. Some of the results here show, not really that surprising, that were fewer infections in the active versus the placebo phase. But again, this was really just not statistically significant. They had still the same number of exacerbations. A couple of the limitations of this study is that there really wasn't any way to assure compliance for the patients. They didn't have any kind of cross-check or balance. They didn't text the patients. They didn't call them to every day to find out if they were taking, or every week to find out if they were taking it. It was just like a monthly check when they did the cultures and the assessments. And then there was some violation of the blinding process. For example, if you take penicillin and you are the kind of person that has really bad side effects, then you know you're on the penicillin, you're on the antibiotic. And then I think during those monthly evals, if the patient did come back positive for a throat culture, for some reason the patients were told, I don't know, by accident or something. I'm not sure how that happened, but that's some of the limitations they had. And then finally, the last study I'm going to talk about is just therapeutic plasma exchange and IVIG, which I thought was kind of interesting and also scary at the same time. The primary objective here was that IVIG to show IVIG and plasma exchange was better than placebo in decreasing symptoms. And so the theory here was that it would either block or remove the anti-streptococcal antibodies that will cross-react with that neuronal tissue in the basal ganglia. I think that's a legitimate possibility, right? So the study design that they used here was that they had an IVIG arm, they had a placebo arm, and then they had a plasma exchange arm. And so the inclusion criteria here that they used, actually, more importantly, the exclusion criteria that they used, if you had Sydenham's chorea, if you had rheumatic fever in the past, autism, schizophrenia, if you had any autoimmune disorder, or if you had an IgA deficiency, and IgA deficiency is a contraindication to IVIG therapy. And so the investigators were, in a way, blinded to the fact if the patient received IVIG or placebo because it's an infusion. So you hang the IVIG, you hang the placebo. The patients and the investigators theoretically don't know who is getting what. And then these two arms also receive Benadryl and Tylenol to offset any kind of side effects. And then the plasma exchange is, I don't know if any of the students have seen it, but it's a little more, there's a big machine that they use. There's really kind of no way to hide that they're getting a plasma exchange. So the participants and the investigators knew that the patients were getting plasma exchange. And so the results of this study, I'm really not that surprised, so you shouldn't be either, was that the plasma exchange in IVIG was actually better than placebo in the treatment of exacerbations of OCD and tic disorders. Have to mention, Dr. Romero's not here, but have to mention that per the American Academy of Neurology, use of plasma exchange is class 3 evidence, so don't do it. And then finally, I just want to talk about what does this mean for us as clinicians? What does this mean for us in our primary care practice? But I'm not going to be primary care, but for all of you that are going into primary care, how does this impact us as clinicians? So in 2017, there was a consortium of different specialists, all from many different departments, such as rheumatology, immunology, pediatrics, neurology, infectious disease, and many others that published some updated treatment guidelines in the Journal of Child and Adolescent Psychopharmacology. And so I think these are some important points that I just want to mention to you, so something that you can kind of take home with you today. First is that this is a diagnosis of exclusion. You have to do a medical investigation for any medical causes. You have to do investigation into any neurologic or psychiatric causes as well. And then the next sort of 3 points that they had published for the updated guidelines are that there are 3 tiers for treatment. The first tier is symptomatic. What does that really involve? That involves treating the symptoms of the neuropsych disorders, whether that's with cognitive behavioral therapy or with SSRIs. The second tier is using antimicrobials. And in this is sort of, I think, a little stickier situation. I interpreted that, there was a really long paper about it, but I interpreted that paper to mean that if the patient was positive for cultures or the blood test was positive, that is when you treat with antibiotics. It's not a prophylactic treatment. And then finally, the last tier of treatment, and this is for extremely moderate to severe patients who really are not able to function in society or at home or at school, is anti-inflammatory and immunomodulatory therapies, which really can be anywhere from NSAIDs to PO or IV steroids or IVIG. So these 2 websites are some really good resources, I think, for parents that want to look at it, or if you would like to look, they quote a lot of the studies that I discussed today. And I think it's important to know about this because I feel like mental health is a huge part of our practice. And a lot of people, a lot of parents are looking for a reason why their child is like this. And so there are a lot of clinical trials still going on right now too at the NIH. And so, like I said, the first point is really important. It's a diagnosis of exclusion. So here are some of my resources. And I hope you all learned something. Any questions or comments? And thank you for coming and staying awake.
Ernie.
Two comments. It's a cloudy issue. If you go back historically to rheumatic fever, the movement disorder with acute rheumatic fever often occurred months after the initial infection. And the problem with that is the antibody titers were already down. So, you know, the movement disorder related, maybe doing ASOs and anti-DNAs are not even a valid test. When you think about that. You know, you'd have to do like carbohydrate moieties for strep, which stay around for years and things like that. So that just clouds the issue as to, you know, trying to make that relationship between strep and these disorders or exacerbations. Now you can look for recent exacerbations. But again, if chorea can happen in 6 months to a year after acute rheumatic fever with no antibody titer elevation, you know, well, you've already got one example of a neurologic movement disorder that it can occur when you have no markers. And one of the exceptions to the Jones criteria would be if you had Sydenham's chorea, you would presume it was acute rheumatic fever with nothing else. And you have to meet the Jones criteria sometimes. So that kind of muddies it. The other comment is, yeah, it's like if I put together a soccer game called PANDAS and set the rules, and if I was losing because the rules weren't working, do I just change the rules and call it something else? Obviously, you know, the PANS covers any kind of neurologic disorder.
Yeah.
Seizures are PANS, you think about it. So that kind of just, I don't know that that clarifies or helps. If you can't prove your point, you just change the rules and change the criteria. Just to keep that in mind. That just, again, is a cloudy issue here. There's probably something there.
I think the original studies that tried to look at whether there was a strep infection in the previous 3 months or previous years were designed to try and help address that first question that you raised, Ernie, about whether there was a later manifestation like Sydenham that happened so late after acute rheumatic fever, or acute after the acute streptococcal infection. So, but I think in part the decision to sort of change that was because, you're right, the goal changed, they changed the goal line, but it was because they could not consistently find strep. And yet there is this acute onset of OCD, tic disorder that happen in children, and trying to, again, try and establish a syndrome as well as determine the etiology, they change the rules. But we still don't have an answer. But we still have parents who have children who have this sudden change, and they read what's on the internet, and they can come in and ask for prophylaxis. They ask for IVIG. They've been, in some cases, treated with IVIG, then they have an exacerbation, and they want more. So I think that people really need to understand where we are with the research. And I think Sonia's, the last slide with the new guidelines, at this point, without knowing etiology or understanding how this all fits, the goal is to primarily treat the symptoms and to use appropriate therapy for the kind of neuropsychiatric disorder that the patient's presenting with to try and gain control and get the patient back to function with a reduction in the symptoms. And so that's been the approach that she very nicely outlined for you. So.
And it is important that the families and parents of these kids really know something's going on. Because I well remember, probably 10 or 12 years ago, we had a morning report of a kid that was felt to have PANDAS, and the mom came, and she was very appreciative that somebody would believe there was something wrong and would support the kid and treat him, even though the diagnosis was not really clear. She really thanked all the pediatricians and said, everybody told me there wasn't anything going on. You tell me it might be this, and you've helped him out. So you really have to realize those parents are out there and they're just looking for some help.
A very good, organized approach to have management. And what to avoid regarding therapy that may have side effects or complications that put the child at risk when it comes to therapy. All right. Other questions, comments? All right. Excellent presentation. Thank you.